Hello. Good morning.
Good evening, sir.
Good evening, sir.
Good evening. Good evening. See, today we'll have demonstration on estimation of serum bilirubin total and direct. Today I joined duty because due to all of sudden I have prepared this PPT. I don't know how it is going to be effective. Anyhow, so they have scheduled program. So all of you are fine. How are you?
Yes, sir.
All are fine. No, anybody is not suffering with any type of.
We are fine, sir. What about you, sir?
Okay. See that. Today the bilirubin, hemoglobin metabolism, how heme is synthesized from alanine and glycine combination, then it synthesizes ALA and all these things. Thereafter there is a two catabolic process of hemoglobin, heme degraded in the spleen by microoxygenase. Then it broken down to separates the globulin and the heme part. Then heme oxidizes to forms the bilirubin. Then bilirubin reductase to bilirubin. Then it is conjugated with glucuronides. Then it transports. This estimation of serum bilirubin is helpful in the differential diagnosis of jaundice. As you know that hepatic, prehepatic, hepatic and post-hepatic conditions. Therefore, we are estimating by the DISO method. There are several methods. This is one of the DISO method. The estimation of serum bilirubin will be estimated on basis of reference range in the less than 1 milligram. This is the normal. The more than 1 milligrams, if it indicates that stress of jaundice. Depending on that conditions, level is increases. There are pathological conditions as well as physiological. There are several conditions what you have studied in the theory. See that there is some slides I have taken. This is the estimation of amount of bilirubin in serum, objective. Then you can see the introduction of bilirubin. Bilirubin is a byproduct of breakdown of red blood cell, which is only 120 days, which is degraded and produced. It is normally, which is present less than 1 milligram. The rest is excreted through excretory route. It is the yellowish pigment responsible for jaundice. What is the metabolic pathway degradation is given here. Bilirubin productions. As you know, can you see this slide clearly?
Yes, sir.
Yes, sir.
Okay. How it degrades by the heme oxygenase in the spleen. So whatever heme is 250 to 400 milligrams per day, which is degrade to forms bilirubin. Then bilirubin reductase to forms bilirubin by bilirubin reductase, which is a coenzyme NADPH coenzyme, niacin, active form of niacin, act as a coenzyme required for activity of this enzyme. Then this bilirubin combines with albumin, binds with albumin, then it circulates. Similarly, we see the extrahepatic, extravascular circulations. See how it excretes in the fecal excretion or enterohepatic circulations. On this slide, you can see that the unconjugated bilirubin combines with the albumin, which forms the hepatic. This unconjugated bilirubin is converted into conjugated bilirubin. Then it goes to small intestine and the fecal excretions or enterohepatic circulations. This bilirubin UDP glucuronide transferase, as you know that enzyme which binds in deficiency, you will get the what condition is called uptake defect is Gilbert, then Dewey-Johnson syndrome. So type of bilirubin, you will get the direct bilirubin, which is conjugated with glucuronic acid, indirect bilirubin, which is unconjugated, insoluble in water. Total bilirubin, sum of direct and indirect of the bilirubin. Okay, type of bilirubin. Is it clear?
Yes, sir.
Any? Okay. See, type of jaundice. Jaundice is the discoloration of the skin and sclera of the eye, which occurs when bilirubin accumulates in the blood at the level greater than the approximate that level what is given is 2.5 milligrams per deciliter. The jaundice occurs. Normally it is 1 milligram. If it is become more than 2.5, then it appears sclera. Sclera become yellowish in color. Skin become yellowish in color. Jaundice occurs because of red blood cells are being broken down too fast for the liver to process. Because of this disease in the liver or because of bile duct blockage, there are any conjugation defect in the liver defect or hemolysis will be more. Certain conditions hemolysis will be more and the bilirubin level increases. Or either liver diseases, any liver disease, hepatic involvement is there, hepatitis, then other any hepatic drug-induced hepatitis or any alcoholic cirrhosis. This condition also, this level is unconjugated. Conjugation will not be there. Unconjugated bilirubin level increase. Conjugation will not take place. Then obstructive jaundice, which is responsible, conjugated bilirubin level is increases. These are hepatic jaundice, pre-hepatic jaundice. There's theory they might have told you. Cirrhosis of liver, infective hepatitis, neonatal jaundice, then post-hepatic jaundice, when obstruction in the flow of bile, cholecystitis. These are the types can be differential diagnosis can be identified by the identifications of biochemical these conjugated and conjugated levels. So perihepatic jaundice, hemolytic jaundice, the productions of unconjugated bilirubin may be exceeds the unconjugating capacity of the liver and hence serum level of indirect and total bilirubin will be raised and that of direct in the upper normal range or just a little elevated. The other liver function test will be usually given in the normal results. This hemolysis will be more. See that hemolytic anemia, excess of hemolysis of RBC, then there will be increase in conjugated bilirubin level in the blood. The upper normal range conjugated bilirubin released to the bile duct. Hepatic jaundice, see hepatitis, the conjugative capacity of the liver is approximately normal, but there is the inability to transport the conjugated bilirubin from the liver cell to the canculi of the binary system and it will be regulated back into the blood. Hence, the serum level of unconjugated bilirubin will be normal. That of conjugated total bilirubin will be raised. Then synthesizing power is diminished, leading to low serum level of protein, which are made in the liver and of the cholesterol, but rising the antibodies to infections usually leads to rise the total protein levels. Then you will have cirrhosis in absence of in the absence of infections. Destruction of liver cell will leads to reduction of conjugating capacity with rise serum level of indirect and not total bilirubin levels, but with the low levels of direct bilirubin and an abnormal high release into the blood of the enzyme or other enzyme, liver enzymes will be increased. Then you will have neonatal jaundice. post-hepatic, here in the bile duct is blocked. What is the diagram shows where it is a bile, the ratio between the bile salt and cholesterol is altered. Then the cholesterol is precipitated, then cholesterol stone, there will be formations which block the flow of the bile. The indirect bilirubin level normal, but conjugated bilirubin is regurgitated into the blood and excreted into the urine. The rise conjugated and total bilirubin both level enzyme will be regurgitated into the blood, giving rise level. The other liver function test normal. If the bile duct are obstructed, direct bilirubin will be built up, escapes from the liver and end up in the blood. If the levels are high enough, some of it will be appears in the urine. Only direct bilirubin appears in the urine. Increased direct bilirubin usually means that biliary secretions or duct are obstructed. This test is useful in determination patient has liver disease or blockage of bile duct. This always the background of the hemoglobin. Still, as you know that any post-hemolysis jaundice, hemolytic conditions, the free bilirubin level increase. In hepatic conditions, both levels are in conjugated and conjugated both will be increases. But only in obstructive jaundice, conjugated bilirubin level is increases. These are by these seeing the values, we can help for the clinician to diagnosis some further evaluations of the liver conditions by ultrasonography and other investigations. The principles of by this method of bilirubin estimation, bilirubin is in serum is coupled with diazotized sulfonic acid to form azobilirubin. The water soluble conjugated bilirubin, direct bilirubin, react easily with the reagents such as diazotized sulfonic acids. While the water insoluble unconjugated bilirubin, indirect bilirubin, so requires solubilized reagents such as caffeine in order to react with diazotized sulfuric acids. In this experiment, the direct bilirubin is estimated in absence of solubilizing agent. Then the further bilirubin is estimated in the presence of solubilizing agent will give the total bilirubin level. The indirect or unconjugated bilirubin is found by the difference by the procedure what method we are using, solution 1 and solution 2 sodium nitrate, then we have solution 3 NaCl, solution 0.9, then we'll use the sample of 0.20 ml and then total bilirubin acid solutions. All this mixture table you can take total test and total blank or control and direct test and direct control. You can take solution 120 microliters ml milliliters, 0.20 200 microliters you can take. So then we have solution to 0.05. This is the procedure what we have to will perform in the laboratory, and once you join here and actually we'll discuss once again how we have to estimate it, how what color you will find by the additions of the reagents. By kit method we are estimating, so that can be will be analyzed in the laboratory. See, calculation parts also you will not understand which will be the Beers-Lambert's law. Concentrate direct bilirubin in milligrams. They have given directly absorption value. You can take direct test and direct blank. Into if you multiply into 14.4, you will get the value direct value. Normal range is 0.25 milligrams. Concentration of total bilirubin in milligrams per ml serum. Again, this is a multiplication factor of 10.8. You will get a direct value in the milligrams per liter. This is one of the method, but in laboratory we are doing the kit method. So there is the calculation method is there. So we'll discuss details into once you join the next schedule online, or we'll once you join back to our college. Actually, we'll discuss all details of the estimation. Anyhow, sorry for this all because of I am also not well. somewhat now improved. Last joined today, they have given told me to this is today's online class. Earlier I have not exchanged with anybody. Somehow I have better. I have to tell you informed to be what we have to discuss in the next class. Okay, just you read. We cannot understand detail of estimation practical online. Practical, it is not satisfactory for anybody. So I will also not get confident to what to tell and what to explain to you in details because the theory might have told details about bilirubin synthesis, degradations, pathological abnormalities, clinical correlations, everything. Okay. So next class we will discuss all detailed estimations and other things. Thank you.
Thank you, sir.
Thank you, sir.
Because okay, all you take rest, be careful. Uh, I am also suffering for last 1 week, fever and cold, but not COVID, but general, I think, most probably some other viral infections. Still, I am getting not stable as such. Anyhow, you take rest. Okay.